Si el doctor Rodrigo Rial está de acuerdo, empezaríamos ahora la última sesión del Congreso Nacional del Capítulo. Es un grande placer para mí, personal, y en nombre de la Sociedad Portuguesa de Angiología y Cirugía Vascular y en nombre de la Sociedad Portuguesa de Flebología, es un gran placer compartir esta mesa. Compartir esta sesión y mucho más compartir esta amistad, que es una amistad muy transparente, una amistad que cada año es mejor, lo que no es muy frecuente hoy por hoy. Entonces es con mucho gusto que estamos aquí hoy, el quinto encuentro ibérico, Congreso Ibérico de Flebología y Cirugía Vascular. Llevamos en Sevilla, en Pamplona y ahora aquí en Vigo. En Portugal lo hubiéramos hecho en Porto, en Braga y un mes estaremos a hacer en Coimbra. Por eso es un enorme gusto estar aquí con vosotros, con todos, en esta sesión. Estamos muy agradecidos con esta cooperación, que es una cooperación entre hermanos verdaderos. Esta es la cosa que a nosotros nos toca muchísimo. Rodrigo, muchas gracias. Empezaríamos de inmediato con lo primero, ponente, Andrea.
First of all, I would like to greet everyone in the audience, and I would like to congratulate the organization for the scientific program, and of course, thank them for the kind invitation. I am Andrea Coelho, I'm a vascular surgeon in Porto. My presentation concerns DVT with indication for indefinite anticoagulation. Is it really forever? I would like to apologize for not speaking in Spanish, but trust me, you wouldn't want to hear me speak in Spanish. I have no disclosures. Venous thromboembolism has a high annual incidence with a substantial economic impact, and recurrence rate can reach up to 30% at 8 years for unprovoked DVT. As we all know, there are several risk factors for DVT that can be classified as major or minor, or as transient or persistent. And unprovoked DVT occurs by definition in the absence of risk factors. Such DVT classification is mandatory for risk stratification, which is essential to determine the risk of recurrence and guide management. Risk of recurrence ranges from very high to very low. And while decisions regarding extended anticoagulation are straightforward at the extremes of the spectrum, for patients at the intermediate range of recurrence, decisions regarding the duration of anticoagulation should include individual patient risk factors such as the risk of recurrence, risk of bleeding, and of course, patient preference. Patients with intermediate risk of recurrence include patients with unprovoked DVT and patients with minor transient risk factors. As we can see in the SVS guidelines, recommendations at the medium range of the spectrum for recurrence risk have a low level of evidence, level C, and are recommendations class 2A or 2B. As a rule of thumb, extended anticoagulation should be considered for patients with a risk of recurrence over 5% per year or 15% at 5 years, as the benefits outweigh the risks. With a better safety profile of DOACs, and better yet for the prophylactic dose of DOACs, of rivaroxaban and apixaban, the recurrence risk considered should be lower. The risk of recurrence after an unprovoked DVT remains high after stopping anticoagulation, and this is irrespective of the duration of initial anticoagulation, which is also known as the catch-up phenomenon. As we can see in this graph, 3 months of treatment achieves a similar risk of recurrent venous thromboembolism after stopping anticoagulation when compared to a longer duration of treatment. So, when the risk of recurrence is intermediate, when should we prolong anticoagulation? Multiple trials have studied the potential role for D-dimers after anticoagulation suspension or residual thrombus in the duplex ultrasound with an uncertain impact on clinical decision. Ultimately, one-size-fits-all of a policy of indefinite anticoagulation for all patients would expose all patients to the bleeding risk of anticoagulation, when up to 80% would not have suffered from recurrence within 10 years without any anticoagulation. Current guidelines recommend the specific durations of anticoagulation therapy depend on individual risk of recurrence and bleeding, and several prediction models have been developed that include items such as age, sex, or D-dimer monitoring with an undetermined utility. Publications of RCTs comparing reduced dose of rivaroxaban or apixaban with full dose treatment or placebo or aspirin have shown that reduced dose DOACs were as effective as full dose treatment in preventing recurrent VTE at 1 year and more effective than aspirin or placebo. A Cochrane systematic review has been published and studied antiplatelet agents for the treatment of DVT, and no conclusions were drawn for antiplatelet agents in addition to best medical practice, compared to best medical practice alone due to very low certainty evidence, so their use in clinical practice is nowadays very, very limited. A very recent multicentric prospective cohort study studying D-dimer and reduced dose apixaban for extended treatment after unprovoked venous thromboembolism, the APIDULCE study. This study confirmed the optimal efficacy and safety of reduced dose apixaban for extended treatment after unprovoked DVT, but it also clearly showed the inability of serial D-dimer monitoring to identify those patients at such low risk for recurrency that should not be offered extended anticoagulation. So in conclusion, no current level A recommendations to guide long-term treatment after an intermediate risk DVT. The role for reduced DOACs should be further clarified to decide which patients actually benefit from such a treatment, and more importantly, the patients that don't, and questions of cost effectivity actually impose. As always, individual patient analysis is key, and there is no one-size-fits-all. Thank you.
Muchas gracias, Andrea.